Zanga. So I'm going to begin my very short presentation by giving you a brief background on gastroschisis, which is a congenital full-thickness paraumbilical abdominal defect with the visceration of bowel into the amniotic cavity. So prenatal diagnosis enables surveillance, delivery planning, as well as immediate neonatal surgical intervention. Despite improving survival in these patients, optimal timing of delivery and predictors of adverse bowel outcomes remain debated, but I'm going to share a few of the recommendations according to the American College and the Royal College of Obstetricians and Gynecologists. So against this background, I'll present a case which was managed through multidisciplinary collaboration between the fetal medicine specialists, the obstetricians, the neonatologists, as well as the pediatric surgeons. So I'm presenting a case of let's call her Miss MS, a 20-year-old woman from Chinoi. She was para O plus 2 gravida 3 with 2 unexplained second trimester miscarriages. So this pregnancy was planned, however it was booked late, and this late booking probably limited opportunities for earlier anomaly detection. We know Dr. Verenga actually told us we can diagnose gastroschisis even in the first trimester. She was then referred to Salim Gabe Hospital at 33 weeks following ultrasound scan suspicion of gastroschisis. So this is a patient who had 3 antenatal visits during the current pregnancy, and these were significant for detection of gestational hypertension, which was diagnosed at 24 weeks. It was, however, well controlled on nifedipine. She did not have any other known chronic illnesses and did not drink or smoke, and when she presented to us, she was at 34 weeks plus 1 day. So at this time of her presentation, our main concerns were to confirm the diagnosis by doing an ultrasound scan, as well as to assess for associated bowel complications, as well as to evaluate the fetal growth. So this is the transverse section showing the fetal head, and this had normal measurements for the biparietal diameter as well as the head circumference. And then we also have measurements for the abdominal circumference, which was low in the 3rd percentile, and femur length, which was at 3.5. So the abdominal circumference should be interpreted with caution, because this is a patient who had a visceration of the abdominal contents. So it would definitely overestimate the finding. However, because we also have a low femur length, this fetus was then diagnosed with asymmetric fetal growth restriction. And then this is just a transverse section showing the abdomen with herniated bowel through the anterior abdominal wall. Of note, you can see that there is no membrane covering the bowel, which then differentiates this finding from omphalocele. And then this is sagittal section showing the herniated loops of bowel. And at this stage, it is important to note that there was no significant bowel dilation or wall thickening, which would then signify complicated gastroschisis. And then we also did an amniotic fluid assessment, which was normal. And it is also very important to note that the amniotic fluid did not have any signs of meconium staining or inflammatory exudate, which also gave us an impression of uncomplicated gastroschisis. The rest of the fetal organs were essentially normal. And then this is the Doppler assessment showing normal umbilical artery and MCA Dopplers. And these are important since this is a patient, this is a fetus which was growth restricted. The placental function remained normal. The fetus also had normal ductus venosus Doppler waveforms, and this was also very reassuring in light of the low biometry measurements. So overall, the findings were consistent with isolated gastroschisis complicated by fetal growth restriction, which was asymmetrical, without any evidence of bowel obstruction, perforation, or fetal compromise. So this fetus was discussed in a multidisciplinary team meeting involving the neonatologist, the pediatric surgeons, the fetal medicine specialists, as well as the obstetricians. And the discussion centered on the poor outcomes that these gastroschisis babies have in resource-constrained settings like our own. So a plan was made to plan for a cesarean section, for an elective cesarean section with immediate neonatal assessment as well as bowel reduction. However, before the date for the planned C-section could arrive, the patient then went into preterm labor at 35 weeks and an emergency C-section was performed. A male neonate was delivered with good APGARs of 8 to 9 at 1 and 5 minutes respectively, and he was then admitted into the neonatal unit. So on these images we see the fetus at day 0 post-delivery, with the urine bag acting as a silo to keep the bowel contents sterile and free from infection. And then at day 2, we see that there is decrease in the size of the bowel contents, and this was after the staged reduction. And at the time we are presenting, the reduction was still ongoing. So just a brief discussion on the fetal surveillance and delivery considerations for fetuses with gastroschisis. It is important to do serial surveillance for fetal growth and bowel complications. These fetuses tend to have growth restriction due to the increased metabolic demand of the bowel contents that are within the amniotic cavity, as well as protein loss from the bowel loops themselves. And as I said earlier, the reduced abdominal circumference may reflect reduced intra-abdominal contents, so may not necessarily mean that the abdominal circumference is low. Doppler assessment guides detection of superimposed placental insufficiency, and it is important to deliver these fetuses in a tertiary center. The optimal time of delivery remains controversial. However, ACOG as well as the RCOG recommends delivery between 37 and 38 weeks. So the outcome is largely determined by the presence of complex gastroschisis. As I said earlier, this includes bowel perforation, volvulus, as well as wall thickening of the bowel. And the management includes primary closure if the defect is small and the bowel contents that are within the amniotic cavity, they are not too large, or stage silo reduction was done in this case. The morbidity includes sepsis, intestinal failure, as well as prolonged hospitalization. Our patient has been in hospital now for about 30 days, so it's a good example of this. Resource limitations significantly influence the neonatal outcomes. These patients tend to do better in high resource settings. So just a few learning points. This case reinforces that gastroschisis can be reliably diagnosed antenatally, as we heard earlier in the first trimester, and surveillance should focus on fetal growth, bowel appearance, as well as Doppler evaluation to rule out complex gastroschisis. And just to reiterate, reduced abdominal circumference may not always represent placental insufficiency alone. Delivery should occur in a center with immediate neonatal surgical capability, so in a center with pediatric surgeons, and resource availability remains an important determinant in terms of outcome in low resource settings, particularly for the morbidity and the mortality for these fetuses. Thank you.